Hello and good evening. Welcome to the Walrus Talks at Home Youth Mental Health. My name is Jennifer Hollett. I am the Executive Director of the Walrus, and we're thrilled to be joining you online in conversation this evening live. I'd like to start by acknowledging the land that I'm on in downtown Toronto, Ontario, Canada, Toronto. A land acknowledgement helps us recognize history, thinking about how it informs where we are now and what changes can be made going forward in a commitment to reconciliation. Our offices and where I'm right now are located within the bounds of Treaty 13, signed with the Mississaugas of the Credit. This land is also the traditional territory of the Anishinaabe, the Haudenosaunee, and the Wendat peoples. Today, Toronto is home to many diverse First Nations, Inuit, and Métis peoples. We're really honored to carry on a tradition of storytelling and welcome you to take a moment to reflect on the land you're on, wherever you're joining us from tonight. As part of the ongoing work of reconciliation, we encourage you to read the 94 calls to action recommended by the Truth and Reconciliation Commission. Now, a bit more about the Walrus. The Walrus was started 18 years ago, really as an optimistic project to tell the stories of Canada and foster conversation. And we do this in a variety of different ways through our journalism, which you can find in our print edition, but also online at thewalrus.ca, through our podcast, The Conversation Piece, and our public event series, The Walrus Talks, which is now The Walrus Talks at Home, my home, and your home. And this work is powered by our donors, our supporters, and our partners. So thank you all for being here, and to Brain Canada and RBC Future Launch for making this event possible. To kick off the conversation, I'd like to welcome now Brain Canada's Chief Executive Officer, Viviane Poupon, and RBC's VP Corporate Citizenship and Sustainability, Executive Director, RBC Foundation, Valerie Chort. All right. What I'd love to do is learn a little bit more about the work of both of your organizations and specifically the history of the work with youth mental health. And I know that you've been working in this arena for a while. So tell us more about that work. Viviane, let's start with Brain Canada.
Well, thank you for the question, Jennifer, but also for the opportunity to be here today for this important conversation on youth mental health. So yes, Brain Canada has indeed a long history of supporting mental health research in Canada. And moving forward, we are committed to increasing the injection of funding in this particular space. I think the COVID crisis has highlighted to all of us the need for enhanced mental health research and care initiatives. And collectively, we really must ensure our healthcare system is well equipped to meet the rising demand for mental health services and treatment options. And our contribution as an organization is to support the emergence of more knowledge through research, but it's also to facilitate its utilization to drive better care and services for people living in Canada. So to that effect, Brain Canada is launching a free national research funding program to really invest in developing and implementing effective prevention and intervention strategies, really with the aim to improve mental health care, and including one program that is dedicated to youth mental health in partnership with RBC.
Excellent. And I know that focus is especially important, which is what we're going to be getting into deeper tonight. So working together, RBC and Brain Canada created the Brain Canada Youth Mental Health Platform powered by RBC Future Launch. Valerie, we'd love to know a bit more if you can share some details and tell us what this project hopes to achieve.
Sure, and we're really happy to support the innovation, with the innovative youth mental health platform. We're most excited by something that we actually co-created with Brain Canada, which was really exciting as we started as a pilot and then really to see how it's evolved. And the goal really is to develop a pan-Canadian resource developed by Brain Canada when research can be housed and accessed by all relevant stakeholders in the sector. And the key there is by convening the best researchers and experts in the field, the platform allows for the exchange of data, knowledge, protocols, and resources that will ultimately benefit stakeholders across the youth mental health community longer term, which we had found was really a real barrier in that context. So the key there is it's open science. It's going to be the first of its kind to collect biological and psychological data from different sources across the country. And we couldn't have thought of a better partner than Brain Canada.
Excellent. Well, thank you so much for your partnership together, but also for inviting the Walrus to be a part of this. We're really excited to follow the work of the platform, but really it's about collaboration. That's the theme here of coming together and sharing that data and work. I think that's how we're going to be able to tackle such a big issue. Thank you both for spending the time with us tonight.
Thank you.
The conversation around youth mental health is extremely timely and important. The stigma around mental health has been in decline, but there are still many barriers to those who need support. According to Youth Mental Health Canada, 1.2 million children and youth in Canada are affected by mental illness, but less than 20% will receive the appropriate treatment. Those are some pretty heavy numbers. And we know that we're at the most sensitive periods of development during childhood and adolescence, when mental health support is critical to the prevention of developing serious mental illness later in life. Yet wait times for counseling and therapy in a province like Ontario are commonly 6 months to a year. Tonight's live conversation is going to delve into what the youth mental health climate is like right now in Canada and what we can all do about it. Here's how this event works. Each speaker has 5 minutes, and once your head is full of new ideas, we're going to have a moderated Q&A session with our talkers and you, the audience at home. So if you have questions for our talkers at any point, please submit them in the comments. In Zoom, that's in the chat box. And if you're watching on Facebook Live, just put it in the comments thread. Tonight, I'm really looking forward to this. We'll be hearing from live Fae Johnstone, Executive Director, Wisdom to Action; Lee Thomas, MSW, Lee Thomas Therapy Services; Dr. Teresa Bennett, Child Adolescent Psychiatrist, McMaster Children's Hospital, and Associate Professor and Jack Laidlaw Chair in Patient-Centered Care, McMaster University; and Dr. Myrna Lashley, Psychologist and Consultant in Equity, Diversity, and Inclusion. Thanks again, everyone, for being a part of this. We encourage you watching online at home to share this conversation on social media. Take a picture of how you're watching us. If there's a quote that really resonates, tweet it out. You can just tag us on any of the platforms at the Walrus, and the hashtag is #Walrus Talks. We're going to begin this evening with Fae Johnstone. Fae, over to you. Welcome.
Thank you. Hello, my name is Fae Johnstone. I use she and they pronouns, and I am the Executive Director of Wisdom to Action, a 2S LGBTQ owned and operated consulting firm that specializes in 2S LGBTQ inclusion and works extensively in the world of youth mental health. I also come to this conversation as a proud trans woman, but also as a white settler joining today from unceded, unsurrendered Algonquin Anishinaabe territory, colonially known as Ottawa. My work and my life have been dedicated to supporting 2S LGBTQ communities, addressing gender-based violence, and improving mental health, and ensuring that our conversations about mental health include and reflect the needs of 2S LGBTQ communities in particular. I also come into this space as a person with my own lived experience, as someone who, particularly as a young person, struggled with my own mental health, as someone who has survived multiple suicide attempts and who lives with ADHD. But I also come to this conversation as a person whose mental health is fundamentally shaped by my own experiences and my everyday reality as a trans woman, and more generally as a trans or 2S LGBTQ person. With that in mind, I want to focus my talk on mental health when it comes to inequity and stigma. First, when it comes to stigma, I actually find myself to be quite fortunate. In most of my mental health related issues, I find that they're ones that are, while still stigmatized, are still nonetheless generally, at least minimally understood and accepted. That doesn't mean that we're not reinforcing stereotypes or reinforcing stigmatized ideas. We most definitely still are. But it does mean that some of our views have shifted, that we have a bit of understanding of what the word depression means and of what depression might look like. However, we don't have the same understanding around suicide and around the ways in which many of us live with suicidality, or the fact that many of us in our world are survivors of suicide attempts ourselves. Persistent stigma around suicide is but one example, but the gist of it is that while we have some degree of inclusion and acceptance for certain kinds of mental health issues, that acceptance isn't extended to those issues that present in ways that deviate more significantly from what is considered socially acceptable. We accept that some folks have anxiety, but we judge folks who have panic attacks in public spaces or whose anxiety makes it harder for them to make a phone call. We accept the idea of depression until someone is literally unable to get out of bed for days at a time. And unfortunately, those are two of the most widely discussed mental health issues, and yet we can see that stigma persists. We've barely begun tackling the stigma and judgment around issues like borderline personality disorder or bipolar disorder. And that means that when folks are struggling with acute needs or have behavior-related impacts associated with their mental health issues, they are hugely stigmatized. Their issues aren't conceived of as digestible, and their behaviors are often more disruptive, resulting in significant ostracization and isolation. People are okay knowing that I struggle with depression, but unfortunately, they're not okay knowing it if they actually see it in practice. They want us to talk about it. They don't want to actually have to see what that looks like in my world. As a trans woman, I also struggle with how often our conversations about mental health are divorced from conversations about inequity and discrimination. For me, there is a direct causal relationship between my struggles with my mental health and living in a world that continues to shame, stigmatize, and enact violence against trans women and all 2S LGBTQ+ people. When I have a really bad day, it's as much about my depression as the struggle of coping with the latest man who hurls a slur in my face, or the latest group of men following me down the street, or joking about my gender, my body, and my transness. When I look at my community, I see 2S LGBTQ young folks who are struggling to survive. I see 2S LGBTQ young folks who are trying to find housing and support, who are ostracized from their families. I see a trans community that has some of the highest rates of poverty in this country, in which 84% of us avoid public space due to fears of public violence. In public policy, in our mental health advocacy, we can't divorce oppression from well-being. We need policy responses that respond to the unique realities and needs of our communities. We need more 2S LGBTQ youth programs, more queer employment programs, better access to transition-related healthcare, and we need campaigns to stop harassment. I want vibrant 2S LGBTQ community services in every city, in every region, in every community. Every year, I feel myself becoming hardened against the violence I face. I get angrier at a world that hurts and that I feel powerless to change. I don't want to become hardened. I want a world where my community doesn't have to cope with this violence. I want a world where trans kids don't have to be strong and resilient. I dream of a future where they grow up safe and supported. We can't talk about mental health without naming this crisis as a crisis of racism, of white supremacy, of homophobia and transphobia, of ableism and misogyny. To bring it to a close, self-care is important, but we often make mental health just about self-care. Self-care is a Band-Aid at best. Band-Aids are important, but they don't address root causes. And those causes, the causes of this crisis, are inequity, they are violence, and they are oppression. Thank you so much for having me.
Hi, my name is Lee Thomas. I'm a therapist based in Fredericton, New Brunswick on unceded Woolastook land. And I would like to talk to you today about disillusionment. I grew up in a small town in Northern Alberta. And like a lot of kids in my town, I had asthma from a really young age. And my town was and is a very industrial town with lumber mills and gravel pits and oil rigs. And growing up, I remember my mom saying, you know, I'm pretty sure the reason that all of you have asthma is because of all the pollution here. And I remember us making fun of her as if that was just the most ridiculous thing we had ever heard. Because asthma was mostly genetic, duh. And if environment is such a big deal, then wouldn't everyone in my class have asthma? And besides, even if that were true, it's not like there's anything we can do about the environment. So we'll just have to figure out how to live with it. And these days, I feel like that's what a lot of my conversations about youth mental health are like. I started getting involved in the field of youth mental health because of my own experiences as a youth with mental illness. And for several years, I worked as a mental health advocate, sitting in boardrooms and doing presentations and consulting on projects to share my perspective as a youth. And every organization I worked with, whether it was a student union or an international research project, was kind of asking the same question. And it's pretty much the one we're asking tonight. How can we better support young people's mental health? And throughout my time in this field, I worked alongside some really brilliant, dedicated people. And we would do this research and these surveys and these pilot projects and initiatives about youth mental health. And we kept getting the same result. People were saying, we are not okay. We are overwhelmed. We need less stress and more resources. We feel like we are being crushed by colonialism and capitalism and trauma, and we are exhausted. We are drowning in our lives. All of our energy is dedicated to staying afloat, and we're miserable, but we're afraid that if we stop, we will die. And we would say, thank you for your time. And we would take this research and we would package it up into some sort of report, and we would put it out there for someone to do something with. And then we would start a new research project, a new pilot project with a question like, how can we better support young people's mental health? And for a while, I really couldn't figure out what was happening there, because it felt like, did we not get the answer to that already? And then I realized there was a second part to that question. That the question wasn't, how can we better support young people's mental health? Because we have so much information about how to do that already. The question was, how can we better support young people's mental health without actually changing anything? And we kept getting answers back that said, we can't, which is why we always needed to do another project to ask the question again in the hopes that we would get a different answer. And I don't actually think we've come to a point where we've stopped doing that, because we're asking the same question tonight. Because if we acknowledge that we have an answer already, it would mean that we'd have to do something about it. And we don't want to, because we don't want it to be the environment. Because when we suggest that the reason that kids are struggling is because their lives are difficult and unsustainable, and that they won't stop struggling until that stops being true, people look at us the way that I looked at my mom back in the 90s. I started working as a private practice therapist in the summer of 2020. So it's been, as we keep hearing, unprecedented circumstances. It feels in many ways like the curtain has been pulled back, and more people are seeing the gears of our world working the way that they actually do, not the way that we'd always been told that they do. And youth perhaps see this more than anyone, partly because they're at an age where they'd be noticing that anyway, and partly because this is now all they've ever known. They saw themselves being herded into schools, not because medical professionals deemed it was safe, but because corporations deemed it was necessary. They've seen governments talk about reconciliation one day and arrest water protectors the next. They've seen powerful organizations make promises that things will change. Then they see those organizations do nothing to fulfill these promises, and they see that there's no repercussions to doing that. They're seeing how grotesquely unfair these systems are, how much of the suffering they see is unnecessary and by design. And it makes them feel furious and powerless and hopeless, because why wouldn't it? How could it not? What I'm suggesting here is not that things are hopeless. It's that hope itself just isn't enough. We have the answers, but we need to be brave enough to act on them. If all the frogs in a pond are sick, you don't look at the frogs, you look at the pond. Thank you.
Hi, my name is Teresa Bennett. I'm a child psychiatrist at McMaster Children's Hospital in Hamilton, Ontario, which is located within the traditional territories of the Haudenosaunee and Anishinaabe people. When I first started as a child psychiatrist about 10 years ago, it was a time when our job started to get pretty busy. Often I'd find myself on call in the emergency room talking late into the evening with 15-year-olds and 16-year-olds. Now, typically in the emergency room, you're focused on the here and now of what's happening that brings them in that particular evening. And so often it was pretty serious concerns that had actually been going on for quite a while, problems with severe depressive symptoms, suicidality, or self-harm. One of the things while we were talking about the here and now, we would drift towards talking about, well, when did you first notice when things didn't feel right to you? And what struck me conversation after conversation was how often youth would talk about how things really started to feel kind of not right around grade 6, grade 7, around the time when their emotions started to become difficult to understand, and life with respect to school, peer relationships, expectations had suddenly become a lot more complicated in many ways. Talking then to their families, we could back up even further. And families would often say that, in fact, they'd had worries kind of a lot earlier, sometimes as early as the preschool years. But they weren't really sure who to talk to about it. And on top of that, families themselves often had been struggling with really quite severe challenges, like things like poverty, things like income inequality, trauma, worried about safe neighborhoods, and parent mental illness. We call these the social determinants of health. What became clear then was that although the emergency room was and is a very important place when it comes to youth mental health, we all agreed that it shouldn't have been the first place that kids were coming to at age 15 or 16 when their problems had been going on for so long. We know that about 1 in 5 kids will have significant difficulties with mental health in Canada, and anywhere from 20 to 30% of these are able to access the mental health services that they need. Things have been exacerbated even further as we work our way out of this COVID pandemic and its significant impact on child and youth mental health. And thinking about these stories from the emergency rooms really made me think about some of the ways in which we need to think about recovering with respect to youth mental health services in the pandemic. First of all, it's really important that we start thinking about things much earlier with a focus on prevention so that youth mental health can be grown over time. Researchers who study how kids grow up over time would tend to agree with what families and youth were talking about as they reflected backwards on their own experiences. For example, prevention programs that are offered during the early preschool years, particularly that focus on family health and positive parenting, can have cascading effects over time into adolescence. It can improve, it can help elementary school children improve their emotional self-regulation, which in turn has effects on decreasing suicidality and substance use, and also improving mood and anxiety problems into the teenage years. Similarly, as we think about that transition to adulthood, thinking about backing things up to pre-adolescence when prevention programs have also shown longer term effects into the adult years when they're offered during the middle school years. Prevention is important, and so is an ecological approach to youth mental health. While formal mental health diagnoses are pretty important, we need to really think about youth's ecologies, and that's the daily experience of kids' environment as they grow up. For example, family mental health, relationships, their connections to school, and policies that either decrease or exacerbate income inequality and social exclusion. When we think about the social determinants of health, which are arguably the most powerful influences on kids' mental health as they grow towards youth, we need to assess them regularly and act upon them in meaningful ways. And finally, these types of approaches need to be baked into our mental health system. Early disparities and mental health challenges start early, and they can have a tendency to cascade over time. We need to level the playing field in order to make an impact as we recover from this COVID pandemic on youth mental health. Thanks very much.
Hello, I'm Dr. Myrna Lashley. I'm a psychologist out of the Jewish General Hospital in Montreal, Quebec. For many years, I worked with youth. I was the one that people called when things went wrong. But which youth are we referring to? I got called for Black youth. So I'm going to talk to you tonight about Black youth primarily. We cannot look at the mental health of Black youth without looking at the environment in which they find themselves. Very often, what happens is that a youth who's having, let's say, difficulty in school, in high school, in elementary school, they're often viewed as being older than they really are. They're viewed that way by society. They're viewed that way by the police. And yes, indeed, they're often viewed that way by teachers. So that in some instances, rather than the youth getting the help they need for mental health problems, school often has become a pipeline into the prison system. Teachers very often look at that youth and say, well, that youth is older or bigger. I am afraid. So they call the police. Rather than calling in the psychologist or calling in a community center, they call the police. It becomes a pipeline. Black youth, the mental health of Black youth is often not treated in the same way we treat the mental health of white youth. That's not a matter of hating on white people or anything like that. It's got to do with the white ideology. And the white ideology has seeped into how we do medicine, how we do mental health care. It is all part and parcel because these are the people by whom we were taught, and we pass on what we've been taught. But we don't look at the social determinants of health for these kids. Racism is a major one. Intergenerational trauma. Let's talk a little bit about racism. Racism is not victimless. No matter how we look at it, it is not a victimless thing. Racism is, as I said, is one of the major social determinants of health. And what do we get? We get people having cardiovascular difficulties, people having addiction difficulties, violence, anxieties, feelings of loneliness, feelings of being excluded. I don't know where I am. I don't know how to fit in. Parents have to have what we in the Black community call the talk with kids. That is to say, we have to take a child who's 7, 8, 9 years old and say to them, you are different. You're the same as your little friend, Michael, but you are different. You are different because when you go to the store and you buy some candy, for example, you dare not leave that store without that coupon, that receipt saying, look, I have bought this. Because you live in a society where someone may come and tap you on the shoulder and accuse you of theft. And if you do not have that receipt, you cannot prove that you did not steal. Imagine what that does to the self-esteem of a child. Imagine the burden that that places on that child. Imagine the embarrassment and imagine the anxiety. You're there with your friend doesn't have to go through that. Your friend's mother isn't or father isn't telling your friend about that. But you have to, and you have to wear the mask. You have to keep pretending that the world is all right, that the world is fine. Of course, it creates anxiety for that child. And if you, even the therapist, the school psychologist, if they're not aware or don't care or don't see it as important, the contributions which the environment brings to the mental health of that child is like a ship at sea without a rudder. The child is alone. The child doesn't know where to turn. The parent will do the best he or she can do to help, but the parent is also going through intergenerational trauma because we know research has shown that if trauma isn't settled in one generation, it gets carried over into the other. It becomes cumulative. And so I'm going to stop there now. And I'm going to say to you that we cannot look at the mental health of Black kids without looking at the environment, the social environment in which they find themselves. Thank you very much.
We just heard from live Fae Johnstone, Lee Thomas, Dr. Teresa Bennett, and just now, Dr. Myrna Lashley. And we're excited to open up this conversation. A shout out to our audience members. Wow, what a group gathered tonight. We have people registered from all over, including Fredericton, Yellowknife, Malaysia, Nairobi, Johannesburg, Tripoli. This is incredible, across Canada and around the world. We have some questions already coming in. You can still submit a question. Just put it in Zoom chat or the Facebook Live comments. I now invite our talkers to come back to the Zoom stage, turn on their cameras, and I have a few questions to get us started. Nice to see you all again. At a high level, how is youth mental health different from adult or say even seniors mental health? Terry, I'll start that one with you. Obviously, younger stage of life, developmental stage, but I would assume there's more to it.
And thanks, that's a great question. I think one of the things that we talk about when I talk about with teenagers is that after the preschool years, really your brain is changing the most when you're during your teenage and early adult time. So this is a huge time where really, really important kind of skills and connections are coming online in terms of your brain development, in terms of how we think and cope and process things. It's also like one of the most important periods of time in terms of our social brain. So, and that's not at all surprising to anyone who's been a teenager or has teenagers or works with them. Their social connections are really major drivers of decisions. And so, that takes a really different approach than if you're working with someone in their adulthood or also during their child years. It's also, of course, a time when it's a major shift. So for those who grow up in, within a family, whether it's, a biological family or a found or adopted family, there's a shift from the kind of the influence of caregivers or parents towards really a growing influence of other relationships, friendships, romantic and sexual relationships. So all of those things kind of come into play. They're important influences that increase.
There's a lot happening in those first 2 decades.
Mhm.
Absolutely. And
Go ahead.
No, I was just going to say it's a unique time. There's no other time like it, really.
Well, yeah, I sometimes think back to high school or see what teens are navigating and think, this is horrible and impossible and amazing all at once, right? This is why so many movies and TV shows are made about high school, because of all the stress involved in that period. And of course, our conversation extends much earlier. I also just want to clarify, especially for those not in the field, how is mental health different from mental illness? Because we often hear the terms used. Myrna, can you kind of just explain what the difference there? There's some overlap, but I just want to make sure we're using the correct terms.
Well, yes, a lot of people think that mental illness is the absence of mental health. And to some extent, there is some truth to that, but that's not quite it. Mental illness is debilitating. It's debilitating. It's not just a simple anxiety. It's not a simple thing like, I feel depressed today. I didn't get my meal on time. I'm depressed. I don't have enough money. That it's not that. And we often use those things interchangeably. And on the one hand, we're talking about wellness. We're talking about coping strategies. We're talking about being able to face life, make good decisions, and cope with it. On the other hand, we're talking about something that can be debilitating, something that drains you mentally, physically, something that makes you feel hopeless and helpless. To me, those are the primary differences.
Great, thanks. Anyone want to build on that?
I think I honestly, these are like, I'm not a clinician, but these to me are things that we're still trying to understand. Like, what is the interplay between biology, between illness, and between socioeconomic factors? Like, I think that piece, I don't know the answer to the question of, can we decrease the rate of mental illness? I do believe that we can decrease poor mental health. We can increase positive mental health. But I genuinely think a lot of this, like when I think about our wealth of research, we've only been researching this for a hot minute in the grand scheme of things. I think we still don't understand more than we actually do. I think that's why we still don't have the perfect solution to these problems, because they're complex problems and we're trying to find the best interventions. But I actually sometimes find the question isn't a necessary one. If you're struggling, if you're in crisis, if you need support and you deserve access to that support. And sometimes access to a diagnosis is still a thing that is used to deny access to care. And so until we're at a point where everyone has the services they need, I think the question isn't a necessary one. I think when everyone has essential services, then we can figure out what the research says.
I'd also add in, like, I frame mental illness very much as it's a social construct just as much as anything else is, which is not always like a super popular opinion, but like, if my grandmother hoards more National Geographic magazines than she could ever possibly read in a lifetime, we see that as an illness. Whereas if a billionaire hoards more, Lamborghinis than they could ever drive in a lifetime, we don't see that as a mental illness. And so that's really influenced by what we value as a society.
Oh, that's such a juicy thought. Thank you so much for that. Faye, I want to come back. In your talk, you highlight how many of us are comfortable talking about, say, anxiety or depression, but when it's a panic attack in public, we start getting uncomfortable, or say borderline personality disorder. I will say, reflecting on my own experiences, sometimes I've been in situations where I feel I don't have the expertise, or I'm not sure how to best offer support to a friend or family member struggling. How can one best navigate it if we're feeling uncomfortable or it's outside of what we know?
I think that's a great question. I think that speaks to something a lot of us feel. We feel our own sense of anxiety when we feel like we don't have the answers or the right response or the right intervention. I spend a lot of my time working with folks on like 2S LGBTQ inclusion, and this is a similar barrier, right? It's the, oh God, I'm so afraid I'm going to say the wrong thing. Almost all of the time, if you ground your response in you aren't expecting me to know everything, you need someone to listen, you need someone to support, you're going to be good to go. And we all actually have different approaches. When I'm working with young folks in crisis, and I've done like peer intervention type stuff, especially early in my career, I use jokes and awkward humor and it responds to the young folks that I've worked with. And that is my approach. And so I think a lot of it is you don't need a checklist. You need it to lean into a relationship, treat folks as folks, as people, as humans, and ask them, what do you need from me in this moment? How can I support you? Be intentional around boundaries. Like, don't, hug someone if you don't know if they want to be hugged. Don't, be intentional on that front. But a lot of the time, if you ask people what they need, they can tell you. And a lot of the time, they just need someone to listen. And that person will not solve the problem, but will give them that is the support they're looking for in that moment.
That's super helpful. Thank you, Faye. Lee, you shared with us a story from your childhood on how we look at asthma, and yay, Mom. To clarify, with mental health in youth, as we understand it right now, because that's such an important point, we're still learning, there's more research. Is it environmental? Is it genetic? What about our own understanding of it, even when we're experiencing it or it's around us?
So the question is about whether or not it's environmental or genetic?
Well, it's the asthma question, right? Like, where are we at with, your mom's point back in the day?
I think it's the idea that we exist separate from our environment, I think, is a very colonial idea and a super medical idea. And I don't think those can be easily like separated from each other. So whether or not it's biology or environment is, I guess, maybe not a particularly separatable thing for me, because I don't think our biology exists outside of our environment. And I think our understanding of it does expand, but I think part of the reason why we keep pushing to learn more about it is because what we have learned about it is that it requires a bunch of changes that we don't feel comfortable making. I think people would be super keen if we could, pinpoint the DNA thing. I don't do a ton of medical stuff. I'm like the DNA point where it's like this particular illness lives and, zap it off of us. I think people would be super keen to do that. But when we know that, making a living wage is also suicide prevention, we're kind of like, but maybe we need to research more about this whole genetic thing. So I think we really try to depoliticize it by making it something that happens outside of the context of our environments.
Myrna,
no,
thank you. Myrna, I'd love to hear your thoughts, especially as it extends to racism.
Well, I was listening to Dee and I was thinking that's good, but what about this? And what I'm thinking about is that as with men and women, when women were always and continue to be defined through the lens of men, we tend to define Black people through the lens of whiteness, through the lens of white people. It's almost, if it's not white, if it's not Black, it must be white. Or if this happens within white people, it must happen this way within Black people. And one of the things we do, when you do the clinical intake interview, one of the things that we do is we try to determine what that illness means within that culture to that person. So we don't just say, this is this. We don't just go axis 1, axis 2. I spent a lot of time over on axis 4, to tell you the truth. We don't just go through axis 1 and axis 2 and say, this is the way it is in our precious DSM form. And I can do a whole thing on that, DSM-5, but we're not going to talk about that. And so I think it's important to recognize that when we do diagnosis, that is a political statement in and of itself when we do that, because we are defining people and we're doing that diagnosis through the lens very often of Eurocentricity. And we've got to stop and take a look at that.
Thank you for that, because that highlights white supremacy. That's what
I was trying not to use the term.
Let's identify it. But I also think you bring up a good point on also limitations of binaries and whether that's white and Black, but it also extends to gender as well. So thank you for that. We have a lot of audience questions coming in. Thank you so much to everyone who submitted. I want to start getting into those now. This is from Kelly in Calgary. In what ways do you see schools, for example, teachers, EAs, counselors, school psychologists, serving a significant role in the provision of support and intervention for students with mental health problems? Faye, you work a lot with youth and students. And actually, that's how we first connected back when you were a high school student. So yeah, I'd love to hear your thoughts.
I love that you brought up that we connected when I was in high school. And I also love that I feel like I don't look like I did when I first met you, which is great to me. So I have the privilege, and my team for the last few years has been working with School Mental Health Ontario. They've actually been doing some incredibly exciting work in this province to support school board leadership on mental health, to provide evidence, to bring best practices forward, and also to make sure that young folks are engaged in that process, that they're informing this work. What I would say is that any intervention we can put in place to help any young person access care if and when they need it is a good intervention. Anything that we can do in this system where there are still significant wait times for young folks to access community-based mental health supports, the closer we can get those supports to schools, the better. I think that our schools are some of the best placed intervention sites, right? Like if we can build wellness in schools, if we can support mental well-being in schools, and if we can also make sure our educators know how to triage folks to care when they need it, that we're making sure that we have those processes well understood and in place, I think that is an intervention that will improve mental health and well-being. Often, though, we have siloed sectors and siloed interventions. I wonder how much the Ministry of Education is talking to the Ministry of Community and Social Services. And so I think we need to see responses that are integrated, because any young person accessing any service related to their health and their mental health in particular needs not only to be accessing that service, but to be connected into a system that can support them on a range of issues based off the severity of their needs, based off what they're looking for in that moment.
Thank you, Faye. And that's my hope, that we can take out of the pandemic how interconnected everything is, whether we're talking about ministries or even in our own communities and lives. I want to get to more audience questions. Shailene asks, how can systems of care from home to community to acute care receive equitable funding and treatment access based on evidence-based research that's available? How can we move from what we know from research to supporting kids, youth, families, and caregivers? Terry, would love to hear your thoughts on that question.
And that's a big gap. It's like, I think I read a statistic once out of the States, it's something like 90% of evidence-based research interventions don't make it into practice. So that research to practice gap is really huge. And that's where this idea of implementation science comes in. So this idea of like figuring out the real world stuff that leads to really often decreased kind of effects of research programs or interventions when they get out into the real world. So you need to actually trial it out. One way, just kind of building on what Faye was saying as well, is this idea of, we know that there's different levels kind of support that you can offer for mental health. So one is this idea of a universal level. And that, for example, in a school would be developing, there's evidence-based universal programs that are studied in school settings where, for example, they build in socio-emotional learning. So kids learn how to create cultures of kindness and compassion and acceptance. Then you can build in a level that we call targeted or indicated prevention, so that people are alerted, teachers and staff are alerted to knowing when kids are having difficulties. And then there's a large group of what we call targeted prevention programs that you can build in. So we work with some researchers in the United States where they've built in this family checkup program into schools, for example, where they have family resource centers. So families can go in and out of schools and access internet services, connections, they meet school staff. And then there's a targeted prevention program. So if parents or youth are having concerns about their mental health, they can enter into this next level, which can then connect them to clinical services if that's what they need. So this idea of, there are programs out there, they need to be studied, and they also need to sometimes be studied together.
Really good point. Thank you so much. John's question for the panelists: are mental health systems effectively now starting to discuss how environment and generational trauma affects mental health? And if not, how can they do better? Myrna, I'm going to send that one your way.
Okay. Yes, it's certainly something that we're doing in my unit at the Jewish General, which is the mental health research unit, the MMHRC, the Multicultural Mental Health Research Center. We're starting to look at it. One of the problems has to do with education. In medical education, for example, psychiatrists, psychologists, we have not done a good job of teaching this. We're starting to do it, but it means that we have to change the way people have taught all along, have been taught and have thought. People have to do some introspection. For example, I'm not going to take a lot of time. Medical students had been taught, for example, that Black people don't feel pain the same way. And so painkillers that Black people may have needed to reduce pain, they weren't giving it to them because they were told that they didn't have the same sensitivity. Dermatologists were not taught much about Black skin. And so somebody might have come into the emergency with a child who had what is commonly referred to as Mongolian spots. That's not the technical term, but everybody knows what that means. So you have the spots, and the social worker was called because they were told, well, this child is being abused, which means that people, if the child needed care, might not have gone to the hospital because they were afraid that the social worker would come and take the kid. So we've got to do something about education. We've got to change the way we teach, not only in the schools, but among physicians and among the rest of the healthcare staff. Otherwise, it's not going to get better because there's nobody there to help them. So you can remove all the stigma you want, but if there's nobody there who's trained to teach those, they're not going to go.
Yeah, and that education's a life's journey. So even if you're a doctor, there's likely something new to learn or relearn as well. Thank you so much for that. This is a commenting question for Lee from Tina. What do you say to the youth who you spoke of about the issues you mentioned and who are feeling so hopeless? Tina agrees that hope is far from an adequate response.
So with a lot of the youth that I work with, this is going to sound like a really counterintuitive response. So I'm hoping you guys will bear with me.
We're here for it.
I really don't see like therapy as a place where people go to feel better, which I know sounds weird. But it's because I feel like in every place that people are, so if we talk about the youth that I work with, in every place that these youth are, they are told to stop feeling hopeless. Because when youth feel hopeless, it bums us out. We don't like when people are feeling hopeless and powerless and furious. So we're kind of like, here's why you're wrong to feel hopeless. Here are the things that you do have control over. Here's why it'll get better, right? And there's a time and a place for those messages, and I, no harm against them. But I really see my practice as a place where they can come and actually sit in how much that hopelessness sucks, which actually allows them to start doing something about it. When I can really be like, yeah, it does feel hopeless. Let's talk about it, as opposed to, yeah, it does feel hopeless. I'm acknowledging it. And now let's try to find a way to get you to stop feeling hopeless. Because I think that anger is a really powerful emotion. I think they are angry because they know that what is happening is not right. And I don't want them to stop feeling angry. And I think when they allow themselves to really sit with that, that's where they start feeling that hope and that intention, and the idea that their inability to live healthily in this pond is not actually because of them, it's because of the pond.
Lee,
I jump in because I love that. I'm just like, I think that is like my ethos. I like to like candidly joke that like my work is fueled by a rage. And I say that, but I'm like, it is. Like, I look at this world, and this world is violent. This world is oppressive. This world hurts to survive in. And we actually need to be able to name that. I think feeling of hopelessness makes sense in a world with an impending climate apocalypse, with white supremacy, with homophobia and we live in a violent world. And I think channeling that and allowing people to come to terms with the fact that this world does actually suck can allow us to say, oh, my feelings actually do make sense. My feelings are a natural response to violence, to discrimination, to inequity. I think that it's consciousness raising. Like, I think so much of this conversation to me is paralleled with like emergence of feminist movements, right? Like this idea that we build consciousness in communities, and that in and of itself is liberatory, is powerful. And I see that as something that needs to happen in mental health. Our anger, our rage is valid. Our rage is legitimate. We have every reason to be angry because this world sucks.
And historically, that's what's changed the world.
And I would say we often think about medical kind of interventions can do harm. We often think about like things like medication and stuff, but you can do harm when you invalidate these experiences. Absolutely. And also when you offer kind of programs that are unhelpful to youth time after time after time. And that, in fact, we can kind of cause hopelessness when we're not being careful and we're not entering into those moments as Lee and Fae were talking about. And that's kind of the power of relationships like psychotherapy relationships.
Well, thank you so much. I wish we had more time, and chat has been blowing up with questions and comments and brilliant response and lots of plus ones. So thank you so much again to all of our talkers. Again, Fae Johnstone, Dr. Myrna Lashley, Lee Thomas, and Dr. Teresa Bennett. Wow, so much to take away from tonight's event. And if you enjoyed the Walrus Talks at home this evening, there's more coming up in 2022. Keep an eye on your inbox. We're going to send you a follow-up email. And the best way to stay in touch with the Walrus and not miss out on any events like this one is to opt in and to sign up for our newsletter. To learn more about the Brain Canada Youth Mental Health Platform powered by RBC Future Launch, we are going to post a link in chat. Click on that and you can read more. The Walrus is a unique beast. We are a registered charity, which means that our content remains fiercely independent and it is sustained through the support of donors like you. So if you enjoyed this free event tonight, please consider making a donation by visiting thewalrus.ca. You can click on donate. We have a fall fundraising campaign underway right now to keep what we're doing alive, and all donations of $20 or more receive a charitable tax receipt. Thank you again to Viviane Poupon, Valerie, Chort, and everyone at Brain Canada and RBC Future Launch for making this conversation possible. Thanks as well to our annual sponsors, Air Canada, Inspire, Labatt Breeze of Canada, Meta, and Shaw. Community is so important in these COVID times, but also when it comes to youth mental health. So thanks for being with us tonight. Each one of you is part of the Walrus. Thanks for tuning in. Have a great evening, and we'll be in touch. Good night.